Good morning, all. I would first like to thank the ESSD for giving me this opportunity to present in this Nestle Symposium on nutrition, advances in dysphagia for patients with stroke, optimizing assessment and nutritional intervention. This is my declaration. So, what are the learning objectives we are going to talk about today? Impact of dysphagia on the nutritional status in patients after stroke, efficacy of medical nutritional therapy in preventing and addressing malnutrition, compensatory treatments that are available, such as texture modified diets, and how to increase nutrient density, use of thickeners in alleviating dysphagia symptoms, and initiating safe swallow to improve the nutritional intake in patients, interdisciplinary collaboration in the management of dysphagia after stroke are some of the points we are going to look at today. So, the stroke and its long-term consequences, we know that with global aging, stroke has emerged as a major public health threat. Dysphagia is one of the most frequent and potential complications of stroke, almost occurring in 37 to 78% of cases, and it is associated with aspiration pneumonia and malnutrition. There are a lot of neurological impairments resulting from stroke, which could be decreased muscle strength and coordination. There are long-term negative mental conditions, just like cognitive decline. There are limited verbal abilities, which significantly impact patients' quality of life. So, the malnutrition causes inflammation, muscle dysfunction, cognitive decline, sarcopenia, which is the loss of muscle. So, what are the long-term consequences of dysphagia? Of course, the number one is malnutrition and dehydration. When there is malnutrition and dehydration, there is muscle breakdown, the decreased functional status, there is decreased swallowing ability. As you all know, that muscles are involved in swallowing, and because of the malnutrition and their difficulty in swallowing, there is high risk of aspiration pneumonia. There is an immunocompromise, which results in increased risk of infections, and there is increased risk of breakdown. And when there is long-term hospitalization, so that causes poor wound healing and a lot of bed sores. So the decreased functional status is a long-term complication of dysphagia because of the muscle breakdown. Now, dysphagia in post-stroke is a nutrition-related disorder. Whether it is acute stroke or a subacute stroke patients, you can see that there is only normal nutritional status in some percentage, but there is mild, moderate, or severe protein energy malnutrition in different percentages, and this impacts overall recovery. When there is an inferior nutritional status, this will result in weight loss, muscle weakness, functional impairment, which is exacerbation of this functional status, and also this ultimately reflects in the long-term rehabilitation outcomes. So dietitians, as a dietitian, I can say that we play a vital role in recognizing the swallowing difficulties because we are the clinical dietitians perform routine nutritional screening through mealtime observations, and the regular monitoring of body weight, food intake plays a vital role on monitoring their nutritional status. So, dysphagia in post-stroke is a nutrition-related disorder, and the grading of risk of aspiration using mealtime observations can be done, and we can classify it as mild risk, moderate, and severe. So, the parameters for the mild risk is when you watch these patients in the mealtime, lengthy meals with reduced protective reflexes, poor tongue control, the restoring of food between clenched teeth, the variable feeding status, the immature feeding patterns, the nasal regurgitation which comes out, the gagging, the vomiting, the delayed initiation of swallow where they keep it as pockets in their oral cavity, that considered as mild risk. But the moderate risk is poor bolus formation. They are unable to do it. The absent protective reflux, the reflux that is there, and the tongue pumping, the gurgling voice, the wet respiration, you can see the change in facial expression as if they are um, very much afraid to swallow, and there is sudden sweating. These are also considered as moderate risk. In the severe risk category, you can see that there is reduced laryngeal elevation, coughing associated with feeding, changes in voice quality, increased respiration rate, sudden change in color, and of course, the sudden sweating and the facial expression is also considered as severe risk. So, the first, as a clinical dietitian's role, the first thing is nutritional status is screened. Nutritional screening first involves where we have to identify whether the patient is at malnutrition risk. Following that is the nutritional assessment, where it is graded for mild, moderate, or severe. And then there is a nutrition diagnosis. According to the nutrition diagnosis, there is nutrition intervention, which is a very personalized nutrition care plan that is devised for the patient, and definitely a continuous nutrition monitoring and evaluation is the most important, and these are within the dietary scope of practice. And all these steps are involved in the nutrition care process. So, how do we do this? The nutrition status, how is it assessed? There is a thorough history that has to be taken. The BMI, the tricep skin fold, the mid upper arm muscle circumferences, the laboratory parameters, where are they in inflammation, the CRP may be elevated. Though the serum albumin and the prealbumin is not considered as a nutritional marker, because it can be elevated also in other clinical conditions, but this is also monitored. Hydration status, which is very important in post-stroke patients. So the bun-creatinine ratio should be less than 15:1. All these are monitored and assessed, and micronutrient deficiencies, so the vitamin panel, and also can be an A, B, C, E vitamins, but this also has to be, the micronutrient deficiency also has to be kept in mind. Validated nutrition screening tools are must. Mini nutrition assessment, it can be a long form or a short form, a subjective global assessment, and nutrition risk score 2002, which is commonly done in the ICU. So the nutritional interventions, what are the clinical guidelines that are recommendation? Let's look at it. So the ESPEN, which is the European Society Parenteral Nutrition Guidelines for Clinical Nutrition in Neurology, states that texture-modified diets and thickened liquids reduce the incidence of aspiration, pneumonia, and stroke patients with dysphagia. And definitely texture-modified diets and thickened liquids should be ordered only following an assessment of swallowing function. So the SLP, which is the speech language pathologist or the swallowing therapist or an ENT, or depending upon the protocol that is followed in each hospital or a nursing home or a care setting, depending upon that, it is first assessed either as a bedside swallowing or as a instrumentation diagnosis, and then based on the recommendation of the SLP for a safe swallow on the HC protocol, the texture modified diet, the grading of that, then the dietitian takes it over and give the correct texture of that. So every stroke patient who receives texture modified diets, thickened fluids, should be referred for nutritional assessment and counseling and monitoring. And every stroke patient who receives texture-modified diets or thickened fluids should be monitored very regularly by trained professionals. So, continuing the clinical guidelines in stroke patients diagnosed with thin liquid aspiration. So, why? Because there is an increased risk of aspiration in thin liquids. Access to water in addition to thickened liquids should be monitored by trained professionals to decrease the risk of aspiration, pneumonia, and the other recommendation is Risk of aspiration can be reduced by increasing liquid viscosity. What this means is post-swallow oral and pharyngeal residues are common, but this can be minimized by using xanthan gum thickeners which are available. So it is the continuous monitoring is very vital. And severe dysphagia, where if it is more than 72 hours, enteral tube feeding, so the early enteral nutrition should be advised, and critically ill stroke patients with decreased level should on mechanical ventilation should receive early, not more than 72 hours. So early enteral tube feeding is advised for mechanically ventilated patients. So, coming to the European Stroke Organization and the ESSD recommendation for the diagnosis and the treatment of post-stroke dysphagia, texture-modified diets and or thickened liquids can reduce the risk of pneumonia. It is and also prescribed only based on an appropriate assessment of swallowing. So everything is very personalized depending upon the clinical condition of the patient, the diagnosis, the infarct, where it is, and so all this is very personalized depending upon the patient. So monitoring a fluid balance and nutrition status is important. Malnutrition can be reduced if we include oral nutrition supplements, supplementation, and early enteral nutrition via an NG tube is definitely important if the patient has severe risk of dysphagia. So, flowchart for the nutrition management of dysphagia based on their nutritional status and the ITSE protocol. So, the well-nourished can have a texture-modified diet with increased nutrient density. Whether it is liquids, then it can be an ITSE 1 to 4. Of course, it is individualized. It cannot be a general one. And then if it is food where it is pureed, or it should be an ITSE 3 to 7. So, when there is a mild, moderate malnutrition, texture modified diets to the individual swallowing capacity is recommended, and thickened oral nutrition supplements can be added to increase the nutrient density to prevent worsening malnutrition. If the patient is diagnosed with severe malnutrition and or they are recommended by nil by mouth, then early enteral nutrition is the way to go. If there is a risk of aspiration, then if there is no, then there is a short term which is advised, which is about 4 to 8 weeks. If it is long term, then we have to look into peg feeding. And if the gut is available and good, we have to use. If there is gut, then we have to use it. So enteral nutrition is the way to go. Only when there is a problem with the gut, then parenteral nutrition is advised, and based on that, then the short term or the long term EN. So it depends upon. So if there is an increased risk of aspiration in an NG tube, then post pyloric feeding, which is a nasojejunal or a jejunostomy, is advised. Textures are depending upon the texture modified diets, which can be nutrition easy to swallow. It should have less hardness and adherence. It has to be adequate, cohesive to facilitate chewing if possible and swallowing to protect from aspiration and reduction of residues in the oropharynx. So safe swallow is the first motto. Increasing nutrient density with adequate calories, protein, and micronutrients is very important. And so the texture modified diets should be cohesive, very, very easy to swallow based on the individual swallowing capacity and a multidisciplinary approach. So based on the ITSE ranking, we can, and also the recommendation of the SLP on the type of the ITSE diet levels, we make individualized plan respecting the food habits of the individual patient and their family food habits. We give them the way of the pureed diet or a thickened liquid based on this. So it cannot be a mixed consistency because that would confuse the patient. So it should be cohesive and it should be modified to the correct level that is recommended. So there is safe swallow and easy to swallow. And of course, nutritious should be the way to go. So nutrition, how do you increase nutrient density? suitable for HC levels 4, 5, and 6, you can add oral nutrition supplements. You can add whey protein isolate. You can add sweet potatoes, boiled, mashed, depending upon the food habits of the regional food habits. You can understand the cultural preferences of the patient and the family food habits and educate the caregiver accordingly. Skim milk powder can be added to increase protein if they don't have lactose intolerance. Date syrup can be added for iron. Jackfruit flour is one of the resistant starch that is available, and that can be also added to increase nutrient density. Now, the effective management strategy to improve this nutritional intake are: you can add thickeners to drinks and food. This is a popular management strategy and a compensation for dysphagia. Thin liquids for difficult for these patients to consume because the low resistance to flow and there is increased risk of aspiration. Thickeners increase the viscosity of the thin drinks and foodstuffs, making them easier and safe to swallow. So you can increase the bolus viscosity so there is better safe swallow to remain in the oral phase for a longer time so the patient can have more time for their reflex responses and the muscular adjustment is done for safe swallowing by the patient. So for recommendation for the nutrition in stroke patients, assess the risk factors for malnutrition with a thorough history and a proper examination. You can do validated tools for the nutrition assessment, the mild, moderate, and severe grading of the malnutrition, assess for dysphagia and aspiration pneumonia, standard protocols to assess the energy and the protein requirements, how to initiate oral food. Maintenance should be done depending upon the different types of stroke. So it is very personalized. You have to increase nutrient density because there is a chance of malnutrition very high and dehydration in these type of patients. Modification of bolus size and fluid or food consistency are effective in reducing aspirations in patients with dysphagia. ONS should be recommended if there is malnutrition and poor oral intake to increase nutrition. EN is preferred over PN and should be initiated once the patients are hemodynamically stable. The preferred EN method is via an NG tube. If there is increased risk of aspiration, then a post-pyloric feeding or an NG feed is initiated. PEG tube feeding should be discussed with families if there is long-term enteral nutrition. A multidisciplinary approach is very strongly recommended because that is the way to go for the positive outcomes for the patient. So the practitioner should identify the process, the barriers, and find solutions for those. So there should be a referral and an assessment, development of an intervention strategy, effective communication with the family, education and training in safe dysphagia management through a multidisciplinary team. Monitoring, evaluation, and reassessment is very vital. So, what are the key drivers for change? The need to standardize a joint approach by clinicians, speech language pathologists, dietitians, physiotherapists, occupational therapists, and nursing team should be emphasized. The need to improve compliance so we can all talk the same language to have positive outcomes on the patient by creating very clear joint accessible documentation for the caregivers and the families so that there is a positive outcome. And this is how the nutritional assessment and the management in this for dysphagia in post-stroke patients is done. Thank you so much for patient listening.